All right. Hey guys. Welcome back to session 8. So today is our last session and the exam's coming up. So you've just got a few days left. I'm sure you know that. I hope that your revision's been going well, that you've had a good week, that you managed to take some study leave and get some time off to revise. I am looking forward to bringing this all together. Obviously, it's been like a pretty tough 8 weeks, 8, 9 weeks for everyone really in preparation for the exam. And yeah, I feel like really happy to have shared this kind of journey with you. As I mentioned before at the start, this is the first time I'm doing this. So at the end, I will, at the end of the webinar, when it closes, there will be a evaluation form. I'd really, really appreciate your feedback just so that I can improve it for next time and see if I am, anything I can improve on. And your feedback is really valuable to me. And I also will be in touch to make sure that I find out how you guys have done and things like that and how the exam went. Also, just wanted to say that hopefully you will, and like definitely really hope that you do pass, but if for any reason you don't pass, then just let me know and I can give you access. I can extend your access to the replays until, for the July reset, or, for whenever you're going to do it. So just let me know. I can try and arrange that on here. So what we're going to do today is the last topic, which is classification and assessment. This topic again is one of the shorter topics, so it's 25 marks, sort of 16 to 17%, which means that it is really important. Shouldn't underestimate it. It's got a lot of things that are fairly straightforward. Today I focused really on some of the things that are quite hard to recall and that people often skip over when revising. So I've focused a lot on a lot of the terminology, the culture-bound syndromes, those kind of things. And also a big part of today, we'll talk about ICD-11 as well, because some of my colleagues, some of my friends and colleagues who, a couple of them are taking this course, may remember I did a presentation in November on ICD-11 updates. I did that just before I sat the December exam, and it was so useful. It came up a lot for me, and so I'm really going to focus on that a lot today, and hopefully you'll find that useful, because I've basically summarized all of the information that we have about ICD-11, so hopefully you'll find that useful. Just coming on to this section of the syllabus. So this is classification and assessment. So, working knowledge of ICD and DSM. I've not focused so much on DSM because it hasn't really changed so much. A lot of the questions now are on ICD 10 and 11, kind of looking at the key differences, as I mentioned. So that's more of a focus. And then we'll go on to some of the other things like the rating scales, and other aspects as well. So hopefully this will be useful for kind of bringing together some of your last minute revision, getting things together in that way. So hopefully we can start preparing for the final few days before the exam. So ICD-11 updates. Why does it matter? Well, obviously we care about it because it comes up in the MRCPsych papers, but it also matters because it is probably going to be implemented at some point this year. So it's meant to be implemented in 2023. Scotland was the first country in the world to implement and promote the ICD-11 for the mental health aspect, and that was from 1st of November 2022 that they officially did that. And yeah, so there's been a lot of the information that I got for these slides was taken from a webinar that the RC Psych ran on ICD-11 updates, and they actually asked the Scottish consultants to give their feedback on how they found it. So that was quite interesting. In terms of the history of ICD, it was started by the French physician and botanist, Dr. Francois Bossier de Sauvage de la Croix, So basically, it's got all of the class of diseases in it, but the main one that we are focused on is, of course, mental health disorders. And the ICD-10 actually was published in 1992, so we've been using that for quite a long time. So the ICD-11 really, that is, you know, we kind of need an update now. So that is a good place to start, really. So looking at the history of the ICD-11, they actually started working on it sort of around 2007, and only now is it coming into proper like fruition in terms of actually clinical use, and it's been approved by the World Health Assembly, and obviously World Health Organization is heavily involved in kind of, you know, trialing it around the world, and is trialed in 14 countries. So the benefits and challenges of ICD-11 compared to ICD-10. So supposedly it's meant to have more accurate diagnostic criteria. It's meant to benefit patients and carers more. And from reports, patients actually prefer ICD-11 to ICD-10. Some of the terminology, which we'll discuss in more detail, they find it more patient-friendly and more accessible. Challenges are that it probably will attract more scrutiny because of some of those terminology changes, and also physical health still code with ICD-10. So there's going to be a bit of a dysfunction where, you know, mental health using ICD-11 and physical health still using ICD-10 for coding. So when we're writing letters and things, that may still, you know, become a bit of a problem. But to be honest, I've hardly ever seen ICD-10 codes used for physical health stuff unless it's, you know, in the actual coding department when you're doing, you know, death certificates or whatever. So not something that you need to really worry about. So purposes of the classification, so health information coding, which is the basis on which access to services funded, and also clinical utility. So this is how we communicate between clinicians, patients, families, admin, how well it fits into clinical practice, and usefulness in selecting treatment interventions and management plans. So basically overall, it's useful for all of those things, and also for research as well, to help find out about different, you know, you have to isolate the disease in order to research it. So you need to have a code in order to do that, and a classification system. So where do we currently use the ICD-10 code? So there's 3 instances that is officially required. So these are when the patient is admitted to mental health unit, we're meant to use ICD-10 code. On the discharge letter, and also there's a yearly inpatient census the government sends around to all of the psych hospitals to find out what is the reason why people have been admitted, and that has to be done with the official ICD-10 code. And then they have announced that there will be new forms using ICD-11 codes, but this has not been announced yet in terms of when that's going to be rolled out. So yeah, so it is pretty important for legal framework, which is also in the syllabus, looking at how mental health act, law, and all these things are involved in our clinical practice. So it's worthwhile knowing about the times when we do use the codes. So when the patient's admitted, on the discharge letter, and with the yearly inpatient census. So coming on to the meat, which we need to know for the real kind of main changes of ICD-10 to ICD-11. Instead of using F, like, you know, how we have like F20 and all of those things for mental health disorders, we are now using the number 6. So that is chapter 6, and so things will start with 6. There is the CDDR, which is the clinical descriptions and diagnostic requirements, which basically is like the description of what the illness is. And so the other things are that it's changed now from a lifespan approach. So they used to have childhood onset disorders separately, older adult disorders separately in ICD-10, but now this has been incorporated all into adult. So that can be a bit challenging, because there are obviously things that are, you know, childhood onset that are now kind of included, as well as, like, for example, the dementias. But we'll look at those in more detail on how that's happened. It does still make sense in the current edition. The other things are they're trying to reduce body-mind dualism, so things like non-organic, organic, and functional have been taken out and replaced by primary and secondary, in order to kind of reduce that distinction between like physical health and mental health, saying like that's organic or or functional. Those have been removed, and that may be one of the reasons why patients prefer it, because it's kind of less, almost less stigmatizing, maybe because of some of the terminology. And some conditions are actually moved out of mental disorders and moved to physical. So like some of the sexual health kind of, when it comes to kind of like the disorders relating to like transgender or gender changes, not to say that those are disorders, but those kind of sexual related conditions have been moved out of mental health to physical. So I think that also would help to promote acceptance of people who are transitioning and that kind of thing, because it now comes under gynae, which I think is probably better. So that's one of the things. And then other things are, I think, like criteria have changed as well. For example, for PTSD, they've increased some of the criteria, and sort of things like that. And we'll touch on that later. But there's kind of like a few key points, and these are the main ones that cover the whole of ICD-11, so the lifespan approach, as well as the removal of those kind of terminologies that create a distinction between psych and physical health. And then in terms of the format changes, so what they've got is the same as before, like category names with a brief description, and then inclusion and exclusion terms, which basically they just mean, those are just like similar to the diagnostic criteria that we had before in ICD-10. So they're trying to include certain symptoms that would create that diagnosis and exclude things as well. And then they've got essential features, specifiers. These are interesting because the way that it's now written is like the course, severity, and symptoms. So they say like long term or like chronic, or and also how bad it is, and then the features. So it is a bit more descriptive than ICD-10. You can learn more about the kind of nature of the disease for the person from just their coding, which is a bit clearer. And then they've got this useful thing which is called boundary with other disorders, and basically it's like a helpful kind of differential diagnosis type of a couple of lines where it will say distinguished from bipolar disorder because of must have some episodes of mania, for example. So it will say like how to differentiate, say, between like bipolar disorder and schizoaffective disorder, and those, the ones that are similar, how to kind of look at those and see what you need to distinguish each one. Then there's the other thing called boundary with normality, and that's also useful because it's saying that sometimes it can just be a normal thing that happens. So when does it become diagnosable as a kind of mental health disorder? And it will say like these things have to be there in order for it to become a disorder. Otherwise, it's just considered kind of a variation of normal. And then structure changes. So yes, as I mentioned before, instead of we're not saying like F20.6 or whatever, now it's kind of changed, and I've got an example of that later, so I'll show you that. And then they've tried to harmonize with the DSM-5, so they're using a lot more, it's sounding a lot more DSM-5 in this kind of way it's written, and that is a move also to kind of help people have more of a uniform way of looking at mental health disorders, because for international conferences, for example, or for research, there's always like, the criteria used for DSM or ICD-10 or ICD-11, so it's a lot more harmonized now. And then they've attempted to group disorders with shared etiology or pathophysiology. So they're looking at putting conditions together that have a similar cause. So that sounds quite useful, to be honest. They're avoiding biological classification, so they kind of like, yeah, the like lifespan approach things. They're kind of making the things less like categorical as such. And now, previously there was 10 groups, and now it's split into 21. And we will go through those groups as well now in the next couple of slides. So the condition changes. So the dimensional approach subtypes have been removed. And there's also been a massive overhaul with the personality disorder classifications. So these are now a very different format from before. So in ICD-10, when we had, like narcissistic, anancastic, all of those have kind of changed in the way that they're written, and I will go through that as well. But that's very, very key to know about. And as I mentioned before, the group and name changes. So they've changed some of the names of like the disorders, like for example, removed functional, and I'll give some examples of that in a moment as well. So yes, as I mentioned, the dementias have been updated, separated from organic, and because of this lifespan approach, they're kind of included in adult now as well. So let's look at this in more detail, really useful way of looking into things. So organic mental disorders, that's ICD-10 on the left, is now split into secondary syndromes and neurocognitive disorders. So yeah, that's, you've got the, that's split into two. So I suppose that's, that's quite useful in terms of those removal of, that organic kind of, the way that they're trying to remove sort of that disparity between them, the physical and the mental health. And then addictive behaviors are added now to substance use disorders. Psychotic disorders and mood disorders are mostly the same, but catatonic disorders are now separated into their own section. So catatonia has its own section. And then anxiety disorders are split into their various components, and somatoform disorders have now changed to disorders of bodily distress. That's a really key point to note. So it's now, the somatoform disorders are now disorders of bodily distress. In ICD-10, anxiety disorders are classified under neurotic, stress-related, and somatoform disorders. And then ICD-11 has now changed that and shifted them to be grouped together into a new category under anxiety and fear-related disorders. So yeah, you can see that there in F40, where it was F40 before, is now like 6B 00 for anxiety or fear-related disorders. And then where it says somatoform in ICD-10, that's now become disorders of bodily distress. So yeah, I think the terminology, patients like it a lot more, and you can see why it sort of sounds a bit more acceptable, socially acceptable, really. And then other things, so we've got the behavioural syndromes, those are split into subgroups. Sleep disorders have been taken out of mental health and put into chapter 7 of the ICD-11 under sleep-wake disorders. They've got their own section now. And that's the same as I mentioned before for sexual mental health. It's been put into its own chapter, which is called chapter 17, conditions related to sexual health. And then personality disorders, they have been separated into different categories, which we'll look at in a moment. And then learning disability and developmental disorders are combined into neurodevelopmental disorders. So this is what I was talking about, the lifespan approach. They've kind of basically removed childhood onset disorders. So all the things that, the learning disability stuff that comes up in as childhood onset is now under neurodevelopmental disorders. Yeah, so from childhood onset disorders, that section disappears, and the two groups that come out of that are also elimination disorders or dissocial disorders as well. So that's quite interesting, really. So all of that area is just kind of covers everything really that was in ICD-10, but it is a lot more categorically organized in a way that's I think it does make a bit more sense, really. So let's move on to the new conditions in ICD-11. So yeah, let's go through this, because this is really important as well. And these are common questions that are, probably you'll get at least at least 1 or 2 questions on the new conditions in ICD-11, just because it's such a hot topic, and it's new, it's going to be implemented 2023, so it's highly likely that something from this will come up. So definitely let's focus on that and go through these. So bipolar 2 has been recognised in ICD-11, so that's the occurrence of at least 1 hypomanic episode and at least 1 depressive episode. We've got complex PTSD, which I'll actually talk about in a separate slide because we need to look at that specifically. We've got prolonged grief disorder in there, which is the abnormally persistent, pervasive and disabling response to bereavement. That's kind of lasting longer than the normal range of kind of 6 months, would be a prolonged grief disorder. Then premenstrual dysphoric disorder is now recognised, which is really good. So that's characterised by a pattern of mood symptoms, somatic symptoms, or cognitive symptoms that begin several days before the onset of menses, so the onset of the period, and they start to improve within a few days after the period starts, and then those symptoms become minimal or absent within 1 week after the period has started. So it's kind of just before the period, they get this premenstrual dysphoric, so like mood, they're overeating or kind of having emotional lability and some other somatic symptoms. So that's been recognised now, which is really good, I think. This one's a bit funny. Intermittent explosive disorder. So this is characterised by repeated brief episodes of verbal or physical aggression or destruction of property, representing a failure to control aggressive impulses. So this has its own disorder now. It just sounds like being a bit antisocial, but this has got its own one now. And then gaming disorder, which is a pattern of persistent or recurrent gaming behaviour, in particular video gaming. So this is becoming a bigger problem nowadays. Compulsive sexual behaviour disorder. So this is a persistent pattern of failure to control intense repetitive sexual impulses or urges leading to repetitive sexual behaviour. And obviously this is only if it's kind of impacting their function that it becomes a disorder. Olfactory reference disorder. So this is where I put it. Yeah, this is an interesting one. Basically, so it's characterized by persistent belief or preoccupation with the belief that one is emitting a perceived foul or offensive body odor or breath, which is actually in truth unnoticeable or only slightly noticeable to others. And this ties in quite well with some of the culture-bound syndromes, which we'll have a look at as well. But basically, especially like Taijin Kyofusho, which is the Japanese one, but basically it's like very much kind of social stuff, like being worried about your body odor. So this is olfactory reference disorder. And then after that, we have excoriation disorder. So this is characterized by recurrent picking of one's skin, leading to skin lesions. And what they do is they kind of pick their skin until it becomes like an even layer. So, like sometimes if you have a bit of skin and then you peel it off and it's kind of a different level to the other bits of skin. So they keep peeling their skin until it's like all the same level. Actually, one of my friends does that when she's really anxious, and it's really off-putting, I have to say. But yeah, and seems very painful, to be honest. Okay, so where are we on excoriation? And then body integrity dysphoria. So it's interesting that the way that they've changed some of these terms from ICD-10, and they've included now these new ones, which is the body integrity dysphoria, body dysmorphic disorder. So we'll start with body. I'm speaking too fast. We'll start with body integrity dysphoria. So that's characterized by an intense and persistent desire to become physically disabled in a significant way, and this has to have an onset in childhood or in early adolescence, usually. But interestingly, so persistent desire to become physically disabled in a significant way. This is body integrity dysphoria. And then body dysmorphic disorder is characterized by persistent preoccupation with at least one defect or flaw in one's appearance, which again is unnoticeable, only slightly noticeable to others. So preoccupation with, like say if the question says, the person's got like a small pimple on the nose, but they think it's like very, very large boil, and then, they keep doing things to look at it, keep checking it and worrying about it, then you'd say that's body dysmorphic disorder. Hoarding disorder, which we've obviously all seen in clinical practice, is very, very common, really, especially in like the elderly and things like, Diogenes, or even with dementias and things like that. But now is recognised as its own disorder. So hoarding disorder has an ICD-11 code. So it's characterised by accumulation of possessions due to excessive acquisition of possession or difficulties discarding them regardless of their actual value. And then the next two are the two new eating disorder ones, which are binge eating disorder, which, I mean, that's a classic. That's a classic feature of many of the eating disorders, but now it's got its own little section, and this is because you can have basically binge eating without necessarily purging behaviours. So binge eating disorder is characterised by frequent and recurrent episodes of binge eating, and not necessarily associated with kind of any purging action. I think that they do tend to feel guilty afterwards, but yes, that's binge eating disorder. And then avoidant restrictive food intake disorder, which is ARFID. A lot of people have come across that as well, and there's people are already being referred to that for clinical, like there's clinics for it already. So this is characterized by abnormal eating or feeding behaviors resulting in the intake of an insufficient quantity or variety of food to meet adequate energy or nutritional requirements. And the way that this has been described to me and how I remember it is basically, like, for example, saying that you only would eat digestive biscuits and just having that as your breakfast, lunch and dinner, because you're avoiding other foods and you're restricting it to only one type of food, which will affect the kind of nutritional intake that you're having. And it's not necessarily, they're not trying to necessarily lose weight or do anything to their, body. They're not obsessed with their body image as such. It's more just like very, very fussy eating gone to the next level, essentially. Okay, so yeah, as mentioned before, I will take questions at the end in the chat. If you guys have any questions on these things, I will get back to you by email after the session. So I know there's quite a lot in this, especially for the ICD-11. I'm trying to power through it, but yeah, do let me know if you have any questions about the ICD-11, about any of these new disorders that are mentioned, or anything I've mentioned so far that's not clear. Okay, so a couple of things to note. These are three conditions have been removed from ICD-11, which were present in ICD-10. So manic episode has been taken out because it's basically incorporated now into bipolar 1 disorder. Asperger's disappears as it's incorporated into autism spectrum disorder, and then all conditions related to sexual orientation have completely disappeared from the mental disorders section. And as I mentioned before, they have now got their own section as sexual disorders, not specifically relating to mental health as such. Okay, right. Now let's talk about the differences in the psychotic disorders. So this is specifically looking at schizophrenia, schizotypal, those disorders that we had as F20 before, and now in this section called 6A20, or like some other ones. So what they've done is they've removed the subtypes of schizophrenia. So they've taken away all of that paranoid, hebephrenic, catatonic, undifferentiated residual simple, which is quite sad really, because I just loved those terms. Like I just felt they really captured the vibe, almost like, seeing hebephrenic schizophrenia is very different from other types, and it gives it like a character. I know I'm supposed to not be selling ICD-10, I'm supposed to be promoting ICD-11, I guess, no, as it's the new thing. But yeah, personally, I really don't. I don't know. It's just also all the literature has got all of those old terms in. So anyway, I shouldn't be oversharing my personal opinion, but yeah, so they've removed the subtypes of schizophrenia. They've now divided it into first episode, multiple episodes, or continuous. And that's kind of describing the chronicity of the disease, like is it the first episode, or is this something that goes on for a long time, or is it kind of background continuous, like low grade, always having symptoms? They've done the same for schizoaffective disorder and the acute and transient psychotic disorders as well. And Catatonia now has its own section, so that's why it's kind of not in that section in F20 anymore with catatonic schizophrenia. It's got its own little department. So that's kind of the main thing to note, really, I'd say, is that they've removed the types and trying to do this more lifespan approach thing, make it easier for people to. It's kind of making it more accessible, isn't it? I mean, hebephrenic or residual is all quite complicated, even for us, as trainees or as doctors. It's already quite hard to learn. So can't imagine what it's like for patients with those diagnoses or, researchers and things. It's pretty difficult. So what is new is the ability to code the symptoms that go alongside the psychotic disorder. So the positive or negative symptoms and the cognitive symptoms. And then you can add additional codes for severity. And the reason I put a picture of frozen yogurt is because this kind of reminds me of, like, when you go to get frozen yogurt and then you can like add things to it to like make it nicer. Like you can add like strawberries, and then you could add like chocolate chips or something. So whereas before in ICD-10 it was like you just had your flavor of frozen yogurt, like mango or passion fruit. Oh, I really fancy that right now. But yeah, so you had your flavor, so like paranoid schizophrenia or hebephrenic or catatonic or whatever, and that was that. With ICD-11 now you've got plain frozen yogurt, which is that they've got schizophrenia, and then you can kind of like grade all of their symptoms. So how much of their how much do they have like positive symptoms and negative symptoms, and then the severity of it, like mild, moderate, severe. So you're getting a better picture of how the patient actually is, rather than having to describe it and read all the notes. You can kind of tell a bit more like what they are like clinically from that. Well, you should be able to anyway, theoretically, from this new way of doing the coding for ICD-11 with schizophrenia and the psychotic disorders. I hope that makes sense, if you know what I mean with the frozen yogurt. Okay, so yeah, this is another really, really key, a really key change. So basically, yeah, so the categorical system in ICD-10 of the archetypes with a description of each type, narcissistic, histrionic, all of that has now been removed. Again, I feel quite sad about this because I felt like they captured the essence of how to describe each kind of characteristic feature of each PD. But they've got their reasons and they've changed it. So we will just have to go with the changes. So the only one that's been kept is the borderline pattern, and the reason for that is because it's the personality disorder with the most evidence for benefit and treatment. Because it's such a specific pattern of symptoms as a kind of syndrome, and it's got like funding for treatment pathways. There's already like DBT and things like that. They've kind of kept borderline pattern, and also it's kind of in line with DSM-5 as well, because that's how it's described in there. So that's been kept in there. And then so how there's this more flexibility with age because of a lifespan approach. This technically means that personality disorders can be diagnosed at any age, which previously people would say, look, you can't diagnose it before the age of 18. So they've now, because that's changed, they're saying like there is more caution for diagnosis under the age of 18, but you can really write things like the developmental typicality of relevant behavioural patterns in evaluating adolescence, which allows for more effective and timely treatment. Basically, what that means is that if someone looks like they're going to develop a certain PD, you can kind of say like they've got traits of developing this, and then that can help them access treatment quicker and have better outcomes because it's, you know, not really late in their life. And then persistence criteria, so how long has the problem been around for, like 2 years or more is like one of the key sort of criteria that they've put. Stability criteria has become more flexible. Personality difficulty is a new category. So what this means is it's basically saying like the person's they're not so bad that they've got personality disorder, but they've kind of just got a little bit of difficulty because of their personality. And so it's described as less severe or persistent or pervasive than a mild PD. So it's like a milder mild PD, a super mild PD. So it's used for formulating people's presentation at time of stress. And then also they've included complex PTSD. So we will go through that because that's super important as well. And actually one of the questions I had in December was about complex PTSD, and I remember I was so happy that I'd literally just done this presentation and like revised all of that complex PTSD stuff. So yeah, we'll go through that in a minute. Okay, look, so this is the ICD-11 way of coding, diagnosing, describing personality disorder. So what you have is basically like step 1, step 2, and step 3. You have like the general criteria for personality disorder. So you can leave at any point, like you can start from the top and you can say like personality disorder unspecified, like you can still leave it at the top, or you can go to the next level. So you've got personality disorder and then mild, moderate, or severe, right? And then you've got these domains. So this is how we are meant to be now describing the personality disorder kind of features. Like instead of writing the narcissistic, histrionic, or, you know, anancastic, all of that kind of stuff as a specific category. I think also because there's been a lot of crossover between the personality disorders, so this does make more sense in terms of describing specific features. But yeah, so you basically rate like negative affectivity, detachment, dissociality, disinhibition, and anancastia as, you know, how much of those traits does the person have. And then the last one, which is separate, is the borderline pattern, which, as I said, because it's so specific and there's treatment pathways already kind of put out, and it also aligns with DSM-5 very well, that has been kept separately. So borderline pattern is its own thing. So yeah, so borderline pattern is not regarded as a trait domain. It's its own syndrome because it includes part of behavior, cognition, relationships, self-concept, and it doesn't fit neatly into the other classic PD you know, kind of way of describing. And as I said, yeah, so borderline pattern is very similar to DSM criteria, which is almost exactly the same as EUPD borderline type, which is described in DSM-5. So it's written as EUPD borderline type in DSM-5. It's written as borderline pattern in ICD-11, but the criteria that they've put basically essentially the same. And then by definition, borderline pattern is almost always moderate or severe just by the nature of the condition. So that's just one thing to note. So let's talk about complex PTSD because I've mentioned it, and again, as I said, it did come up in my exam, and I remember it really clearly. So definitely something worthwhile to note. So I used to think that complex PTSD was somebody who had like complex trauma and that led to PTSD, and that's why it was called that, but it's actually not. There's actually 2 triads that have to be present. So the first triad is the PTSD triad at the top, the yellow one. So that's re-experiencing, avoidance, and hyperarousal. And they need to also have the second triad, which is basically like a kind of personality thing that's happened, which is self-concept disturbance, emotional regulation disturbance, and relationship disturbance. So that's the green triangle. So those 2 triads have to be present for complex PTSD to be diagnosed. And then just an important thing to note is that if there's more personality disorder traits, so if it's more than just that green triangle combo of personality stuff, so self-concept, emotional dysregulation and relationship, like interpersonal relationship issues. If there's more than that, then you should think about an additional diagnosis, or an alternative diagnosis even, because they could have PTSD and personality disorder, but this complex PTSD is basically saying they've got this trauma from this event, and it's also affected like the way they view themselves, their kind of lability emotionally, and it's kind of almost like borderline-y, like symptoms, but not as bad, not as severe as like a full borderline pattern, because you've basically got this with the PTSD symptoms, and it's not complex trauma as I previously thought. So that was quite a revelation to realize that. Okay, so I hope that makes sense to you guys. So you need those two triads to diagnose complex PTSD, and it's basically PTSD with some like personality stuff, but not bad enough to be a PD. Yes, so this is basically a bit more detail on how they're grading the personality disorders. I don't think you need to know this for the exam, because it's a bit, it might be a bit too much of them to ask, like specifically how each section of personality disorder is going to be now diagnosed in ICD-11. But just so you know, just in case there's kind of anything relating to the severity, it is graded as mild, moderate, and severe personality disorder, and that's kind of the sections that it's graded as. And you can see what the kind of things they're looking at. So disturbance in functioning of self, so like self-functioning, and then disturbance in interpersonal relationships. So like when they've got mild PD, it's saying like they're having problems in many of their relationships, but they're mild problems, whereas in severe PD, you can see it says virtually all relationships are affected by their PD, and they've got severe problems from it. And then other things you see like harm to self or others. So like rarely in mild PD do you have like harm to self, whereas in severe it's like often, and then moderate's obviously in the middle. And then disturbance in personal, social, and occupational functioning. So there's in mild it's like moderate impairment or mild impairment, and then for severe it's like severe impairment, so like they can't go to work, or it's really messing up their career, that kind of thing. So this is how they're now looking at grading these personality disorders. So they've kind of, you can see that they've done this throughout the whole of ICD-11. Like they're grading like the psychotic disorders, they're grading these personality disorders. They're kind of getting more of a feel for like how bad is the problem for each of these diseases, which I think, yeah, is a good thing really. But and again, so I mentioned that they've gone and removed these ways of explaining personality disorders. So they haven't got this like schizoid or histrionic. So all on the left, you can see those names, dependent, anxious, EUPD, dissocial, schizoid. They removed that, and instead they've got these 5 domains. If you remember the slide where I've said, they've got personality disorder, and then you've got like 5 different traits, and then you have to say like how bad each trait is. This is what's called a crosswalk, which means how would you explain someone who had like anancastic personality disorder from ICD-10? How would you now describe them in the new way of ICD-11? And so you can see, for example, in anancastic, you would rate them on negative affectivity and anancastia. Or like, for example, in histrionic, instead of putting histrionic, you would say they've got negative affectivity, dissociality, and disinhibition. So it's kind of like breaking down the components and like mixing and matching and saying like they've got a bit of this and a bit of that, and this is what it looks like. Instead of saying categorically this person is histrionic or this person is anancastic, we're now like got these kind of qualifiers, which is, yeah. So this table is just from the CDDR website, which is basically like for clinicians who are trying to change their coding. So on their letters, they've got someone who's schizoid, like how are they going to now write about them in the new ICD-11 way of writing? So this is like a tool for clinicians. So again, I wouldn't worry about learning this specifically, but I would definitely remember that those five like qualifiers for personality disorder are now replacing the old way of just saying narcissistic or dependent, because that is quite a key change. And I've just included some of the references and links for those ICD-11 updates that I used, in case, because it's quite new and everything, there can be changes and things. But I've looked at this quite recently, so this stuff has only just come out. So do feel free to kind of have a look and see, look at the ICD-11, have a look at how it's laid out. And if you have time, you can watch the ICD-11 implementation webinar. But to be honest, I don't think you need to, because I've summarised everything that they've said in this, in these slides, and you probably don't really have time to do that. But yeah, maybe in the future, if you're looking at ICD-11, that could be something that you could look at. So let's take a break there, because it's just been coming up to we've been going for about 45 minutes, 46 minutes or so. So let's take a 10-minute break there, and we'll come back for the rating scales and psychiatry, have a look at some of those. Yeah, so come back in 10 minutes. All right. Okay, hey guys, welcome back. I hope you had a good break. So let's get started on the scales. So hopefully you've come across these a lot in questions before. They can be a bit tricky to kind of recall exactly, but some of the key things are whether it's self-rated or not and kind of what it does. So we'll go through a few of these and just quickly touch on them as a revision aid. So Beck Depression Inventory, which is BDI, that's used to assess the severity of depression with a total of 21 items, and each score is out of 0 to 3. And the scale, it goes 0 to 13 is like minimal depression, 14 to 19 is mild depression, 20 to 28 is moderate, and 29 to 63 is severe. And then we've got Zung self-rated depression scale, so it's ZSRDS, and that is also for severity of depression, self-rated, and there's 20 items on the scale. Each one is out of 1 to 4. We've got the HADS, so that's done in the hospital anxiety and depression scale. Then geriatric depression scale, which is 30 items, looking for depression in the elderly. Again, 10 to 19, 0 to 9 is normal, 10 to 19 is mild depression, 20 to 30 is severe depression. Edinburgh postnatal depression scale, I think you probably will have come across that one specifically, but just see. I'll come back to that one. PHQ-9, so that is the 9-question patient health questionnaire, which asks patients about the last 2 weeks of their kind of subjective experience. So how much have they been bothered by problems like thoughts of self-harm and other things. So depression and severity can be related to that. So 0 to 4 is none, 5 to 9 is mild, 10 to 14 is moderate, and 15 to 19 is moderately severe, 20 to 27 is severe. Nice to have a little change it a little bit where they've got on the PHQ-9, if it's less than 16, that's subthreshold and mild depression, whereas it's more than 16 on the PHQ-9 score, that's considered moderate and severe depression. And then the LUNSAS is the Liverpool University Neuroleptic Side Effect Rating Scale, so that's looking at side effects of neuroleptics. And then the last one is the DES, which is Discontinuation Emergent Signs and Symptoms Scale. Again, that's looking at severity of the side effects. I'll come back to the Edinburgh postnatal depression. Can't find my note on how many points it has or anything. So let me just see if I can find that. Otherwise, we'll come back to that later, or I'll just send something out. Okay, so we'll just move on to the clinician rated scale. So there's quite a lot more of these, which you can imagine, because there's only so much data you can get subjectively from self-reports. First one is a Montgomery-Asberg depression rating scale. So this is MADRS, which is a 10-item diagnostic questionnaire used to measure depressive episode severity, and it's also designed to be more sensitive to the changes from treatment and medications. Then there's the Hamilton depression rating scale. So this is called HAMD, and that's multiple choice questionnaire used to rate severity, and there's either 17 or 21 items depending on the version used. Each item is scored out of 3 to 5 points, and then the total points is severity, obviously. For 17 item version, which is the more common version, scores range between 0 to 54, and over 24 indicates severe depression. And then we have the BAS-DEC, which is the Brief Assessment Schedule Depression Cards. This is a screening test for depression, and it uses a deck of cards with statements. And it was originally developed for busy wards, like inpatient wards where people are in their cubicles with the curtains. They can just pull out these cards and say how bad is this, or they say true or false to it. For example, my mood has been very low, and then they say true or false. And there's 19 cards with a maximum score of 21. It takes less than 5 minutes to do, and a cutoff score of 7 is generally used. And then we have the Young Mania rating scale, which is a YMRS. I was going to say YMCA, the YMRS, which is 11 items used to assess the severity of mania in patients with bipolar disorder. I think that one's quite easy to remember. And then the brief psychiatric rating scale, this is for schizophrenia. So this is a clinician-rated scale used for schizophrenia, and it evaluates their kind of severity and also their symptoms. So 16 items, and then they added 2 more items, so there's 18 items now, and then they expanded it again to 24 items. So they added more items to measure additional things like self-neglect, distractibility, suicidality, and bizarre behaviour. And then we have the PANSS, the PANS, which again is also for schizophrenia. So that's looking at positive and negative syndrome scale. And it looks at lots of things. So it looks at reports from hospital and from family and from interviews with other people apart from patient. And the information is gathered, and it looks at the past week. So all of how they've been in the last week according to people around them. And it's got 30 items to it. And then the abnormal involuntary movement scale, that is a 12-item scale looking at the dyskinesias in patients who are taking neuroleptics, so antipsychotics and other things. And it looks at how bad it is, where they are of the movements, the distress associated with those movements, and it's used for assessing tardive dyskinesia in clinical trials. And it's quite easy to use apparently. Yeah, and then Simpson-Angus scale. So this is a 10-item scale, and that's for neuroleptic induced Parkinsonism. And it's looking at, it's got 1 item that looks at gait, hyperkinesia, 3 items that look at glabellar tap, tremor and salivation, and then 6 items that look at rigidity. So that is the Simpson-Angus scale. And then CGI is the clinical global impression. This is looking at like the global thing. So this CGI and GAF, this is like a global rating scale. So CGI is called clinical global impression. It requires the clinician to rate the severity of the patient's illness at that particular time, and it's relative to the clinician's past experience of patients with the same diagnosis. So yeah, so it's quite dependent on the clinician. So it's basically saying, like, compared to the clinician's previous experience of other people with schizophrenia, how do you rate this person? So it kind of depends on the experience of the clinician there. And then GAF, which is Global Assessment of Functioning, again is also like a global scoring thing. So this provides a single measure of global functioning. Is about their occupational and psychological function. It's scored out of 100, and 100 is kind of like the best score that they can have, and it kind of shows like how well they're functioning like in life on the whole. Then Y-BOX is the Yale-Brown Obsessive Compulsive Scale, which is looking at response to treatment and also severity. And then the last one is the CAMDEX, which is Cambridge Mental Disorders of the Elderly Examination, which is developed to assist in looking at dementia, and it looks at clinical interview, cognitive tests, and interview with patient's relative as well. So those are the main ones for kind of, those are self-rated, so not that many, kind of like 8 main ones. And then you've got the clinician rated, so you've got quite a lot more clinician rated scales. And this is a scale that just should be mentioned, which is also looking at global functioning. So along with GAF and CGI, you've got this other one, which is called SF36. It's 36 items, it's patient reported, so it's patient reported to self-reported scale, and it looks both at physical and mental health, so that's why it's like a global one, and looks at all these kind of other things, and it takes about 8 minutes to complete. So this is another scale that sometimes gets mentioned. And this one, which I think looks like Who Dat, but it's Who Das, which is basically again another global assessment, but this is like the DSM's global functioning tool, and yeah, it looks at kind of similar things like daily activities like society, how much they're participating in things, their self-care, mobility, and like interpersonal functioning. So this is for DSM, their global assessment tool for functioning. And then let's look briefly at the attitude scale. So I'm going to ask you at the end as well to do a Likert scale for my webinar, so maybe you can see it in real life in action. So basically the Likert scale are statements of like agreeing or disagreeing with a series of statements, and it goes from strongly agree to strongly disagree. Then you've got Thurston scale. So this is kind of like a statement that is written, and then you put a score of like how much they agree or disagree with each statement. But it's not like where you're rating it. It's like kind of categorical. I actually don't have an example for that one, but yeah. So a person can have a score of 0 if they disagree with all the items. It's kind of more like agreeing and disagreeing rather than rating it. So Thurston is more like that. And then semantic differential. So this is like presenting pairs of things. So like cold and hot, and then usually it's like a 5 or 7 point scale, and then looking at scoring in between that. And it's always like opposite things, or like opposite adjectives. And then the Gutman scale is cumulative scaling, and it's a list of statements as well. So then we'll say like how much did they agree with the scoring with each statement. So those are just the main attitude scales. Okay, and then so this is the ACE, so Adam Brooks cognitive exam. So this is a tool for detecting dementia, and just included this because just the note about kind of like the scores for cutoff. So if you're using a cutoff of 88, it's very sensitive at detecting dementia, and the specificity is 96, whereas at 82 cutoff, because basically different, the different places use different cutoffs. So with 82, it's not as sensitive, but it's more specific. So how do I say that? Basically what it means is that if you're using, if you're saying your like cutoff is at 82, then it's quite sensitive for detecting the dementia, but it's not as sensitive as using, a higher cutoff score. But when you're using that lower score, there is a risk that the cognitive impairment could be actually related to something else, like pseudo-dementia, cognitive impairment, or atypical Parkinson's syndrome. So yeah, the point of ACE is to differentiate Alzheimer's from a frontotemporal dementia, and it's got those criteria in it that you're looking at, those different sections. So attention and orientation, memory, verbal fluency, language, and visuospatial. I'm sure you guys have all come across doing an ACE before. It's quite long. So let's talk now about the disorders of perception. And sorry, I'm literally rushing through because it's just like there's just a lot of random stuff in this topic, and I just want to make sure that I get through everything that's important for us. So let's talk about types of hallucinations. So I'm sure you've come across these already in the question banks, but just to whiz through them and run through them, make sure that you know them. So auditory, obviously we know like they either hear their own thoughts or second person or even third person. There's also thought echo, which is echo de la pensée, which is hearing one's own thoughts aloud after thinking them. And then there's also Gedankenlautwerden, which is kind of like similar to thought echo, but it's basically they hear their own thoughts at the same time as they think them. So like they think, oh, I should go and have a coffee, and then like they also hear that at the same time. Then visuals, obviously more, it's more found in the organic Well, we're not meant to say that anymore, are we? Okay, but I'm still going to say it. Organic conditions like alcohol, withdrawal, or like related to substances, or epilepsy, temporal lobe epilepsy. Gustatory is hallucinations of taste. Olfactory hallucinations of smell. And then tactile or haptic are related to touch, so like feeling like a bug crawling on you is like a common one, which can be different from like formication, which is the feeling of crawling on your body, but it can just be like a haptic sensation, or like a feeling of water running down, or like a cold wind on your arm or something. And then extracampine, so these are hallucinations beyond the possible sensory field, so hearing like someone shouting your name from Yugoslavia would be extracampine. And then functional is experiencing a hallucination at the same time as receiving a real stimulus in the same sensory modality. So I think the example that is often used is like someone turns on the tap and they can hear the water running, and at the same time as the water is running, they can also hear like someone speaking. And then that's different from reflex hallucinations, because these occur in a different sensory modality and responsibility to a real stimulus in another one. So like, say you turn the tap on and you can hear the water, but then like you see like a ghost coming out of the tap. So that would be like a reflex hallucination, because it's a different sensory modality. And then Lilliputian, these are hallucinations where they see like small people, like Lilliputians, like in Gulliver's Travels. And then kinesthetic, so these are related to hallucinations of muscles or joints, and they feel like their arm is like being like twisted around, or like being like they're being like pushed around, or like their arm is like being twisted into some like their joints being like broken backwards, all those kind of things. That is like kinesthetic. And then hypnagogic, so these are when patients are going to sleep, so these are normal experience. And then hypnopompic are when they're waking up, and like these are just normal, sort of like, you know, when you have your alarm going off and you're just kind of hallucinating, or that kind of thing. And I always remember it by and it sounds a bit silly, but like, you know, the word like pompous, like someone's like quite like thinks they're really great. I like to think like you want to think that you're great when you wake up in the morning. So like hypnopompic is like a pompous person wakes up in the morning. So I always remember it as that one. So hypnopompic is the morning waking up, and then hypnagogic is kind of like falling asleep. And then autoscopic, so this is when a person's seeing like a double of themselves, like a copy of themselves in their space, but they aren't leaving their body, so they haven't left their body, but they're seeing like another copy of themselves. And yeah, so that's some of the hallucination types. And then looking at the types of illusions. So illusions are altered perception of a stimulus. So it's different from a hallucination, because with an illusion you do have a real stimulus present, like a shadow or something like that. And you can have these different types. So you have affect, we can have affect, pareidotic, and complete illusions. So complete illusions are when the brain fills in kind of missing information to make sense of a stimulus. So for example, like the classic one is like a black bin bag or something. You see it out of the corner of your eye and you think it's like a man in the corner, but it's actually just a bin bag. Your brain's like filled out like some of the information it hasn't received. Then pareidotic illusions are when you see like people or faces or like shapes on things that are not necessarily there. So like looking at the clouds and like seeing the face of like God, or you know, any kind of like the face of Elvis Presley. I don't know, anything random. And then affect illusions are these are related to kind of affective states. So like if you're scared, you might think of something more like threatening, or as if you're like if a person is in a like aggressive or like agitated mood, they might perceive things as like being more like dangerous. So for example, if you're like in a situation where it's a bit dangerous, and then someone like puts like there's like a shape or something, you might think it's like a gun, but it's actually not, for example. So Yeah. Then the sensory distortion. So these are related to kind of like how the sensations can change. So you've got hyperesthesia, which is increased intensity of sensations. This can occur with intense emotion, but can also occur like normally in like ASD and in autism that can happen. Hyperacusis, that increased intensity of noise occurs with anxiety, can occur with panic disorders, migraine, hangovers, also autism as well, and some like learning disabilities, if you remember. And then hypoacusis, so decreased intensity of noise, not like hearing less, basically, is seen in some conditions, and like medication related or delirium. And then change in quality of senses as well. So gustatory changes, like with lithium, you get the metallic taste, or like with other medications, it can change like the taste aspect, and then also derealization as well. These are some of the visual distortions. So chromatopsia, which is where objects are not the right color, or they kind of look the wrong color, like abnormally colored. Pelopsia, which is when objects appear nearer than they are. Teleopsia, which is when they look like they're further away than they are. Micropsia, the thing looks smaller than it is. Macropsia, the thing looks bigger than it is. Dysmegalopsia, which is the thing looks bigger on one side than on the other side, so it's kind of like uneven. That can occur with lesions in the lobes of the temporal lobe and the parietal lobe, and sometimes also in schizophrenia. And then metamorphosia, so this is when the object looks irregular in its shape. Okay, so let's move on to, sorry, this is not absolutely whizzing, but yeah, so let's move on to alcohol. So yeah, I've just picked out like some of the key things that I just think are so important in this topic for the exam, and these are some of the things sometimes we forget to revise, but like the physical findings in alcohol misuse or alcohol dependence. So you get hepatomegaly, caput medusa, so that's the bottom left picture, which is those kind of distended abdominal veins. Feta hepaticus, which is the smell and the breath. Flapping tremor, gynecomastia, which is top right, testicular atrophy, palmar erythema, bottom right picture, and spider nevi, which is the top left picture. And these are the most important blood tests for the alcohol-related disorders. So ALT is raised, the MCV is raised, the gamma GT is raised, and the AST is raised. But the gamma GT is the most reliable indicator of recent alcohol misuse. And these are some of the kind of screening tools that we use for alcohol. So audit, which everyone's probably quite familiar with. This is a very simple method to screen for excessive drinking. The original audit screening questionnaire has 10 questions, but we often use the audit C, which is just the 3 questions. But anyway, the scores. So in audit, in the full audit questionnaire, if a man scores 8 or more, then they have hazardous or harmful alcohol use, or 15. If they score 15 or more, that means they have dependence. And then in women, if they score 7 or more, this is out of 10, they have hazardous or harmful use of alcohol, and then 13 or more, they have a dependence on alcohol. The FAST scoring tool was developed for like use in like busy medical settings like A&E, and it kind of has a maximum score of 16. Hazardous drinking is a score of 3 or more, and if they first answer to the question is never, then they are not misusing alcohol. But if they answer like weekly or daily, then it's usually like in 50% of the time is going to be a harmful level of alcohol use. CAGE is a 4-question screening tool where you ask them basically about cutting down, whether they're annoyed by people who like criticize their drinking, if they ever feel guilty about drinking, or if they ever have a drink in the morning. And so 2 or more positive answers mean that they have a problem with alcohol. Okay, so SASQ, another alcohol scoring system, and the reason I've included this is because sometimes question might be like, which of these is not a scoring system for alcohol dependency or harmful use? So now that you kind of have an idea of which ones are important for alcohol, because it's also just such a big part of our clinical work as well. It's a single question. So when was the last time you had more than 6 or 8 drinks in one day? So for women, you'd ask 6, and then for a man, you'd ask 8. So when was the last time you had more than 6 drinks in one day to a woman? And if they say that within 3 months, within the past 3 months, that indicates harmful, hazardous drinking. Or if they say 8, and if they say yes, and it's 8, then for a man, that's the same as well. And then the Paddington alcohol test, this was developed to use for busy A&E departments. And again, it's just another screening tool to look at alcohol use and dependency, and that's Paddington there. And then these are 2 more, so MAST and RAPS-4. So MAST is a Michigan alcoholism screening test, and it's useful for detecting dependency in drinkers, whereas the RAPS-4, which is Rapid Alcohol Problem Screen 4, consists of 4 questions and is also found to be effective for detecting alcohol dependence, and a yes to at least one of the 4 questions suggests that harmful is drinking? Drinking is harmful. And the questions are, have you ever had a feeling of guilt or remorse? So that's the R. A is amnesia. So have you ever been told that you've forgotten what you've done in that time? P is performance. So have you ever not done what you were supposed to do because of drinking? And S is start a drinker behaviour. So do you sometimes take a drink when you first get up? It's quite similar to CAGE, really, isn't it? So just to note, that's MAST and RAPS-4 as well for alcohol. Then a quick note on the big 5 personality traits. It just doesn't fit in. I'm sure we've covered it before when we did maybe the first session or second session, but just a reminder, these are the big 5 personality traits. So openness to experience, which is O, conscientiousness, extroversion, which is also known as urgency, agreeableness, and neuroticism, which is emotional stability. And the mnemonic is ocean, that's why there's a wave there. So that is the big 5. All right, let's move on to Catatonia. So basically Ludwig Karl Baum, he is credited with the original description of catatonia, and obviously it's the psychiatric syndrome of disturbed motor functions with disturbance in mood and thought, and it's got its own section now in ICD-11, which is really important. We'll just run through these just to make sure that we know them. So posturing is maintaining the same posture for a long time, and an extreme type of posturing would be like catalepsy. So they might hold posture like that for a while, or a specific type of thing. Stupor is immobility and mutism, so kind of just basically very still and very quiet stupor. Waxy flexibility or seria flexibilitas, which is when the patient is in uncomfortable postures and maintained for a considerable period of time. It's interesting. I guess it's similar to posturing, but with waxy flexibility, the patient can be positioned into those postures, and then they will maintain it. So you can put the hand up here, and then it will stay there. And then negativism, which is also known as Gegenhalten in German. So when the person resists the examiner or the doctor's attempt to move their body with exactly the same strength. So their arms here, and then they're trying to push it down, and they resist it with exactly the right amount. I don't know how that works, but that's quite interesting, really, isn't it? And then Mitmachen is a form of automatic obedience. So the body of the patient can be put into any posture, even if the patient is told, please don't let me put your arm into this posture. And then the body part immediately returns to the original position. So this is different from waxy flexibility. So you can say don't let me move your arm, then you move the arm and it will spring back to where it was before. So that's Mitmachen. Now, Mitgehen is a very extreme form of Mitmachen, where the patient's body is moved by the examiner by the slightest touch. They have this thing called angle poise lamp sign, and the angle poise lamp is you know, those lamps, and then like you can just like really adjust them like a little bit. But then it does go back to where it was before. But basically it's saying like a very extreme version of Mitmachen, where even the slightest touch can like change their position. Okay, what is next? Automatic obedience. I think oh no, I didn't do that one. So exaggerated behavior where they obey everything that the clinician tells them to do. And then ambitendency is the kind of the patient will like comply, but also like not comply at the same time. So like you could say like, could you put your hand on your head, and they'll be like, put it, and then like put it back, and then keep putting it there. So that's ambitendency. And then motor perseveration. This is when the patient continues doing a movement that is no longer like relevant. So like say you ask them to like pick up this pen, and they picked it up, but then like they keep going to like do it again and again. They keep like persevering with that behavior. That's motor perseveration, and that's a feature of catatonia. And then continuing with more features, so we've got force grasping. So the patient will repeatedly and like with force grasp the hand of the clinician when it's offered. So like if you put your hand near them, they'll keep like grabbing it. And then psychological pillow. So this is really interesting actually. I've seen this once and I won't forget it because it looks so strange. Like the patient's like lying down, like as though they're about to go to bed, but like the head is like a few centimeters like above the pillow, like the pillow's like here. And it's like I don't even know how they like keep that position, but that's a psychological pillow. They can keep themselves in that position for prolonged periods. And then obstruction is when the patient is doing a movement and then suddenly just stops doing it and is unable to give a reason. And it's kind of like thought block, but like a physical version of thought block. Echopraxia is when the patient is copying the actions of the interviewer. So like when you're gesticulating, they're like copying what you're doing. And then, yeah, so then mannerisms. So these are goal-directed movements, which are repetitive. So they are like you're trying to do something like smoke a cigarette, but like there isn't actually a cigarette, but they just keep doing that. And that's like a mannerism. And then that's different from stereotypies because stereotypies are not goal-directed. So that they'll just be like a random movement like wiggling or like rocking. So that will be stereotypies versus mannerisms. Mannerisms, like you could see like what they might be trying to do, like put a hat on their head and keep taking it off. Aversion is the patient will like look away or like move their body away from the examiner. And then echolalia is when the person repeats what the examiner is saying over and over again. And then verbigeration is a meaningless repetition of phrases or words. So they keep repeating the same words, for example, without any meaning. And then logoria is just like saying words that make no sense, like keep saying them. Okay, that was a little bit of a whiz. I'm excited about this bit. So now we're going to be talking about the culture-bound syndromes, just running through these because it can be quite hard to just visualize and learn just from reading them. So hopefully these will help jog your memory and remember them in the exam. So Koro, this is a interesting, strange one. Basically, it's a belief that it's from sort of Southeast Asia and China, but it's actually found now like in lots of different places. There's been loads of case studies of it, even in like the diaspora, so like even in England and things. You can get this. So it's a belief that the sexual organs are retracting into the abdomen. So for men, obviously that's a penis. Oh my god, my cat is saying hi. Can you not disturb me, please? And sometimes they do extreme things like ask people to like tie down their private parts so that it stops them from being retracted into the abdomen. And the belief is that if it does retract, then they will die. But there's no visualized actual changes to the stop it, cat. To the actual genitalia. Okay. The next one is buffet délirant, and this is a French one, and and it's basically just acute and transient psychotic disorder, and there have been historical case studies in France for this. So this is like a French asylum picture. DAT is a syndrome where it's from South Asia, so like kind of like India, Bangladesh, Southeast Asia as well. They get these symptoms of anxiety, somatic symptoms, and tiredness, and they attribute this to loss of semen from masturbation usually. And basically, there's like kind of lots of like herbal remedies and things that people take to stop this from happening. And the next one is Attack de Nervios. This is like a Latino descent thing, kind of like Spanish type of origins, where after intense emotional upset, the person gets like a seizure-like episode or dissociates or becomes like starts shouting uncontrollably, and it can be after a distressing event. It's also related to panic disorder. You can also just get nervios, which is another way of saying it, so attack of nerves or just nerves. And it's common in Latinos in the United States and Latin America, and it's related to general state of vulnerability from stressful life experiences such as emotional distress, somatic disturbance, and it causes an inability to function. So this is amok. So you may have heard of the phrase like running amok. So this comes from this, and it was first seen by Captain Cook, I think, when he went to like the Philippines and to Malaysia actually. So yeah, he noticed it, or the people, like some of the like colonizing forces went and saw that like in tribes this would occasionally happen, where it can happen without provoked attack, like provoked insult, or it can just happen randomly. But occasionally, like a man would become insulted and like go away for a few days and then like come back and then just have a blind fury and kill everyone in their path. And then they would have amnesia for the episode if they are caught. So the only way to stop this amok is to kill the person who's doing it, or to kind of like tie them up and then like wait for them to kind of snap out of it, basically. And on average, they would kill around 10 people. Yeah, so pretty bad. Brain fag. This occurs in the African diaspora, and it originated in Nigerian students, and it includes cognitive disturbances such as concentration difficulties. They find it hard to like study. They get like vision changes, and it occurs during like intense intellectual activity such as exams. I feel like this is quite normal for like most people who are studying for exams. So, but yeah, it's considered a culture balance syndrome. So. Hiao Cap, and I don't know if I'm saying that right, probably not, but this is a Cambodian culture balance syndrome. That's a picture of Angkor Wat. Basically, what it means is a wind attack, and the belief is that wind rises up in the blood, and this will like then go into different parts of the body and cause different symptoms. So if this wind in the blood rises up too high, it will compress the lungs, cause like suffocation. And it can also, they feel like it might go into their brain, and they can get symptoms of tinnitus and other things. And it is seen in Cambodian refugees who have been traumatized, who have PTSD, and it has been noted actually not long ago. So these culture bound syndromes are still quite relevant to current clinical practice as well. And the main symptoms are the autonomic arousal. So like they do get those kind of physical sensations, and panic attack as well. This is Kufungisisa. I'm just saying it however I feel like it should be said, but probably not correct. These are from the Shona people of Zimbabwe, and the belief is that thinking too much causes anxiety and depression. Yeah, I would agree with that. And they can also get somatic symptoms as well. So yeah. And then Latar is usually found in Malaysian women, and this is when they kind of have a hypersensitivity to sudden fright or startle, and it can be a very odd behaviour. So they can even have things like coprolalia, where they like there's interaction with like feces, like throwing feces or eating feces, and also dissociative phenomena as well. So this is in Malaysian women. Maladi Moon, which is in Haitian people from Haiti, And this is kind of like an evil eye concept where someone's like envious or jealous and they send an illness to that person. And so this can have like various different symptoms because it kind of depends on whatever that person who is envious of you has done to you. And it's kind of like a superstitious type of belief. My cat is trying to open the door. Oh, it actually has. She's opened the door. Okay, that's fine. As long as she's happy to get out. Okay, and then Piblocto, which is also known as Pibloktok or Arctic hysteria. This affects the Inuit people, especially the Inuit women, and they have been seen to start doing dangerous or irrational things. So supposedly this is when I was doing some Googling of Piblocto, this is like a scene from some kind of thing that happened. Can't really tell you what it is, but they do things like they can like harm people, like start screaming, or like, you know, kill people, and they have an amnesia of the event as well. And then the next one is Shenjing Shuairu, which is in Mandarin Chinese, and it means a weakness of the nervous system. And this is kind of like a syndrome which combines the traditional thoughts around like Chinese medicine with Western neurasthenia. So like they get mental fatigue, they can get like neurological symptoms, emotional ability, headache, insomnia. They also get this thing as like a sense of failure or guilt, and it can be triggered by work or interpersonal stresses. Susto is like a fright. It means a fright, and this is again found in Latino people in the States and in Latin America. And the thought is that it's a frightening event which scares a soul out of the body, and symptoms can actually occur from days to years after the event. So it doesn't even have to happen straight away. And sometimes it can be so bad it results in death. It causes effects on appetite, sleep, kind of mood, sense of self, and motivation. Taijin Kyofusho. This is like similar, I think, I don't know if you remember when I mentioned the olfactory reference disorder. So they have these kind of persistent beliefs that like they're not culturally appropriate, like their social norms are like not good enough. And it can be also related to like their like body odor or like bad breath or like greetings or like behaviors that they're doing, interacting at work. And that their appearance or actions are inadequate or offensive. And I think because the Japanese culture is quite like very specific about their cultural, like their customs and politeness, and this is something developed from that. And it can be classified as sort of a culture-bound social phobia or interpersonal fear disorder. And I love this one, it's my favorite, I think. This is Wendigo. This is in the North American tribes, the Native Americans or First People. So they this was developed, like this theory of why they get this is there's like harsh winters and starvation. They begin to have loss of appetite, and then there's like this kind of psychotic phenomenon where they believe that they are turning into like a cannibalistic ice spirit called a Wendigo, which is that thing there, and that causes cannibalism. So there have been like cases where people have eaten their families. Okay, so powering through. We've got still got a bit to go, to be fair. We'll just keep going. So the ego defenses. Right, let's go. So we've got level 1. So this out from Valent. These are the ego defenses that are basically like the ego creates to maintain its sense of self and how it interacts with the world, the external world. So in level 1, these are common in healthy individuals before age 5 and common in adult dreams and fantasy. But this is the very like most basic, ego defense, and this is like a pronounced break from objective reality. So delusional projection is frank delusions about external reality, usually about a persecutory type. And then you've got denial, which is refusal to accept reality, and then distortion, so reshaping external reality to suit inner needs. Level 2 is the immature ego defenses. So they're also known as the narcissistic defenses, and they tend to comfort the person who's doing them but annoy the people around them. And these occur in individuals aged 3 to 15, or people who have not like developed after that, and they are socially undesirable. But they can change with time, so they can improve with time. So like in psychotherapy, or like confrontation, or like kind of just like friendships, that kind of thing, school, these can all be developed and kind of matured. So splitting is, having like black or white thinking about things, which is typical of like the borderline personality syndrome types, borderline pattern. Projection is falsely attributing your own feelings to another person. Projective identification, so aspects of the ego are projected into another person, and the difference between the two, so projection and projective identification, which the difference is that there's you take into account the emotional impact of the person who is being projected onto. And then in projective identification, there can be a sense of feeling manipulated, but that person can feel that. Schizoid fantasy is a tendency to use fantasy and use that to avoid conflicts. And then hypochondriasis is transformation of kind of behavior towards others into like somatic things, so like anything that they don't like interacting with, maybe turned into like a physical complaint. Passive aggression, so this is aggression towards others through passivity, or directed against the self as well. Acting out is like impulsive actions which help avoid dealing with those like anxious thoughts, so like impulsively spending loads of money, for example. And then regression, so this is when people revert back to like previous, like more childish, infant-like stages of development when they have to deal with something unpleasant. And then we have the level 3 neurotic mechanisms. So these occur in kind of most adult people ages 3 to like older age, like 80s, 90s, and these are kind of like they can be changed again by psychotherapy, but these are like some things that can just be present in people's personality and how they might just deal with things. So dissociation is like thinking about things in like a very like non-emotional way. So like the thoughts are there, but there's like no emotion behind it. The repression is kind of like failure to like acknowledge something, just kind of like not reacting to it. Displacement is redirecting feelings to another person, another object. And then reaction formation, which is like behaving the opposite way to what you think. Like say if you have like an enemy and then you just give them like a cake or something because you're like, I don't know, that's reaction formation. And then intellectualization is like, again, taking out the emotion of something and intellectualizing it with facts and logic and like working out how to do it without using emotions. And then undoing is like trying to act as though like nothing had happened. So, like smashing up someone's car and then like covering it back up as though like nothing had happened, be like undoing. And apparently Freud used the term ungeschehen machen, which translates to make null and void or to make unhappen as one of his things. And it can be seen in like crime scenes and things like that. And then the next one is the level 4 mature ego defense mechanisms. And these are the, the highest levels. So altruism, humor, suppression, and sublimation. So altruism is, helping other people. That's a mature ego defense. Humor is like expressing things in a funny way without maybe upsetting yourself or anyone else. And then suppression is postponing things, so saying like, I'll think about it next week, and then thinking about it next week. So you do remember to think about it, so it's different from repression. And then sublimation is like turning things into like another form. So like going for a run instead of like screaming at someone. Okay, so let's go on to delusions. Right, so first thing to note is the difference between the primary and the secondary delusions. So the primary delusions are known as orthogonous. I don't know how to say that. I hope that's right, but anyway, that's how it's spelled. So primary ones are like delusions that come out of like normal life. So like my example was a yellow car drives past, and that means that aliens have come to collect you. Sort of what I was thinking when I wrote this. And whereas secondary delusions can be considered as more as like a person's attempts to make sense of their psychotic phenomena. So they will like maybe hear a voice first and then be like, oh, like, you know, the neighbors are trying to kill me, because they've heard a voice like that they think might be the neighbor. So it's kind of like that comes like the psychopathology aspect is more happens more in the secondary delusions, whereas the primary ones are like come out of normal day-to-day life. The types of primary delusion can be delusions of perception, delusional perception, delusional memory, delusional mood and atmosphere, and sudden delusional ideas. So delusional perception would be like what I just said, like a yellow car goes past. That means like you're going to be, a spaceship's going to come and beam you up. Whereas like delusional memory can just be like, oh, I remember when I was 8, I had like a matchbox, and that means like now I have to, I'm going to, you know, be set on fire or something. And then delusional mood is like not like just a feeling of unease or disease, like you can't put your finger on it, like something just feels off, like you just feel like something's not right. And then sudden delusional ideas can just be about anything really. And then the types of delusions, so these can be like the way that they're organized. So like they're either logical or paralogical. So logicals are consistent delusions. So like they'll say like, there's this man who wears green and he always like comes to my work and he like tries to make me eat a donut. Whereas like a paralogical one is like it changes every time. And then organized and logical ones are systematized, like they've got like, you know, like the man in green and like he drives his car and like he lives here and like I know he lives there because I've seen him, and like they're kind of like organized and like logical. Excuse me. And then types of delusions in delusional disorder, yeah, so you probably know this already, but they're usually like persecutory, hypochondriacal, or like grandiose delusions like in affective disorders. And then delusional beliefs can have a relationship with reality. So polarized is the term that's used when delusion and fact are mingled together. So say, for example, there is a man who wears green and comes to their work, but obviously he's not forcing him to eat donuts. So there's a polarized delusion. Whereas the juxtaposed one is like the delusion and the fact exist side by side. So like they go to work, the man is wearing green, and there is, you know, these aspects of it that are also delusional. So there is fact in it and there is also like delusion in it, but they're not mixed together, they're like separate. And then autistic is when they literally have no contact with reality, everything is like completely delusional and there's like no like acknowledgement of real reality. And these are just like some revision slides are made just to try and like revise these quickly. So I'll just whip through those. So Campgrass delusion. So the person that they're close to, like their father or mother, has been replaced by an exact double. Frigoli, which is the people that they meet day to day, are actually the same person in disguise. So like you go to the shop and the man in the shop is actually the same person as like, you know, the Uber driver. But they're all just like disguised and they're actually just one person. And then subjective doubles, so people believe that they have a doppelganger, so like they have a double. Intermetamorphosis, so people have swapped identities, but they look the same. For example, you look at your sister and you know in your head that's actually your mother, but they just like, they look the same as how they were before. So like you just think that they've just swapped identities. That's intermetamorphosis. A mirrored self, so you look in the mirror and you believe it's not yourself, it's a stranger. I like this too, but delusional companions, so non-living objects possess consciousness and have emotions and can think independently. I find this really interesting actually, because I think I follow this girl on Instagram who does this. Well, I don't know if it's like a joke. It might be a joke, but it's quite concerning. I feel like it's quite normal to do it a little bit, like, you know, with cuddly toys and things, but delusional companions. Clonal pluralization of the self. So this is multiple copies of the self that are physically and psychologically similar to your original self. So this is like lots of clones of you, so not just a subjective double. And then this is a concept called reduplicative paramnesia, and this is like more about like places. So these are also kind of like delusional misidentification syndromes, but like they're more about places. So extravagant spatial localization. So the current location is actually a different place. Like, say for example, current location is actually like they're in the hospital, but they're like, actually, this is my house. Which is different from chimeric assimilation. So that's the last one on that list, which is that the places are actually combined. So like they are both at home and in the hospital at the same time. So I feel like this is quite like a dream-like state. Like, I don't know if you've ever had a dream where you're like, oh, I'm at home, but like it also looks like work, and it's just that's like chimeric assimilation. Whereas it's extravagant spatial localization is like they deny that they're in the hospital. They're literally just like I'm at home. And then place reduplication is when there's like two copies of something, like two copies of the same house, but they're in like different places. Other types of delusion to be aware of. So this is a picture of Ian Brady and his partner Myra Hindley, who had like a folie à deux, reportedly. They were responsible for abduction, rape, torture, and murder of 5 young victims called the Moors murders. So this is a shared delusion of folie à deux. There's loads of cases of it online where people kind of like have a shared psychosis. Egg bomb syndrome is a belief that a person's infected with insects. Othello syndrome is the thought that the partner is cheating or like being unfaithful. Lycanthropy is a belief that a person's been transformed into an animal. I think this originated from like belief about werewolves. De Clerambault syndrome, which is a false belief that someone is in love with them, and it's usually someone of like a higher status or like a famous person. Again, I also think I follow someone on Instagram who has this. Catatonia syndrome, so a belief that your body has died or that you're already dead or it's like rotting. And then referential delusions, so delusions of reference, like the TV's talking to you or about you, or the radio talking about you. Pseudopsychosis is the belief that a person, like a lady usually, is pregnant when they're actually not. They can get physical symptoms of pregnancy as well, bloating, things like that. So, yeah. Right, we'll go through the movement disorders and then hopefully we'll get to the end soon. So just kind of like, this is just revision stuff, really, like, you know, like just really key stuff like for the exam, just to refresh the memory. So bradykinesia, you know what that is. It's a Parkinson's core symptom. It's slowness of voluntary movement. It's found in Parkinson's disease. It's also found in progressive supranuclear palsy and MSA, multisystem atrophy. Akathisia is a symptom of restlessness. It can be a side effect of neuroleptic medication. It's usually caused by antipsychotics and calcium channel blockers, as well as anti-vertigo drugs and antiemetics. Akinesia is a very severe form of bradykinesia. It's basically like not moving at all. They have things like they hardly blink, and this is found in Parkinson's. It's found in progressive supranuclear palsy and MSA as well. Athetosis, this is like a continuous stream of flowing, slow, writhing, voluntary movements, and it's like worm-like. I was trying to just work out like if it's like that. Well, I don't know, but I feel like that's quite worm-like. And it's in cerebral palsy, Huntington's, stroke, Wilson's, and can also be a feature of using donepezil. Whereas chorea is apparently faster than athetosis, so that's the difference. So athetosis is the worm-like one, whereas chorea is meant to be like faster. Okay, I don't really think that is an accurate way of describing it. So if you do want to see it, maybe have a look on YouTube. But when you compare athetosis to chorea is faster, more dance-like, and affects the proximal kind of muscles and area as well as the distal. It's found in Wilson's disease, Huntington's, spinocerebellar ataxia, hypothyroid, lots of different things you can see there, hepatic renal failure, anticonvulsants, lithium and cocaine. And these are brief, irregular, quasi-purposeful contractions, and they flow from one muscle to the next. Dyskinesia is from drug-induced reactions usually. Parkinson's dyskinesia can be from dopamine agonists, whereas tardive dyskinesia can be from dopamine antagonists, and it's general problems with voluntary movements. Dystonias are involuntary, intermittent, or sustained muscle contractions, repetitive movements, twisting movements, abnormal postures, and they're obviously caused by the antipsychotics, as well as like loads of other medications and like physical conditions as well. So the dystonias, like ocular gyrate crisis, for example, other things like that. So the dystonias, torticollis. Parkinsonism is the triad of tremor, rigidity, and bradykinesia. A tic, so this is often found in Tourette's, usually, occasionally also in Huntington's or stroke. They are suppressible behaviours which are involving discrete muscle groups and are sudden, non-rhythmic, stereotype motor movement or vocalizations. Myoclonus is a shock-like jerk, which is a sudden involuntary contraction or relaxation of one or more muscles. Can be normal, like when falling asleep, the hypnic jerks. Or it can be kind of like pathological in stroke, epilepsy, poisoning, MS, Parkinson's, Alzheimer's, CJD, and they're repeated, brief, and non-rhythmic. Pretty sure everyone's had that thing where they feel like they're falling and then have that myoclonic hypnic jerk thing. Tremor, so lots of causes of tremor. It's usually involuntary. Multiple causes, anxiety, caffeine, can be just hereditary, like essential tremor, hypothyroid, Wilson's, alcohol can cause it, lithium valproate, so medications, amphetamines. Hemibolismus, so this is repetitive, large amplitude involuntary movements of the proximal limbs, and it's found in stroke, TBI, amyotrophic lateral sclerosis, non-ketotic hypoglycemia, and infection. Stereotypies, I think we mentioned this before as well, but these are simple movements that can be suppressed voluntarily, and they can be caused by autism, sensory deprivation, and LD. So got a couple of more useful points just before we finish off. So just a few more slides. I think just like 3 or 4 more slides left. But Kraepelin's mixed state. So basically, sometimes there's a question about what were Kraepelin's like mixed affective states, and these are he basically came up with this thing where patients have like both manic and depressive symptoms at the same time, and like there's can be transitions from like one mood state to another, and he found like there were these 6 mixed states. So depressive/anxious mania, excited depression, depression with flight of ideas, manic stupor, mania with poverty of thought, and inhibited mania. Sometimes that question is which of these is not one of Kraepelin's original 6 mixed states. But then also, what was I going to say about it? But yeah, so over time, those 6 mixed states have been reduced to 2 main types. So dysphoric mania, which is when there's full mania but with some depressive symptoms, and then depressive mixed state when there's full depression but they've got a few like manic symptoms. And they can also use other terms like agitated depression when there's depression with psychomotor agitation, anxious depression, which is depression with anxiety, irritable depression, which is depression with irritability, mixed hypomania, hypomania with some depressive symptoms. So those 2 are the kind of outcomes of those 6 states, so dysphoric mania and depressive mixed state. But these are the original 6 Kraepelin's mixed states, kind of mixed affective states. And then this is also something that occasionally is relevant, which is the doctor-patient relationship models. So like informative is when the doctor gives information to the patient and then the patient decides themselves. Interpretive is when the doctor helps the patient make a decision based on their situation. There's like shared decision making, and the participation of the patient is very relevant. The doctor understands what's important to the patient. Deliberative, which is when the doctor acts as a friend to the patient and purposefully gives them advice towards like a particular thing which they think is their best interest, but ultimately the choice is left to the patient. And then paternalistic, which is an autocratic model, assumes that patients don't know anything and doctors know best, and the doctor's simply supposed to just give the information and the patient's supposed to listen, which is obviously the worst one. I think the best one is like interpretive and deliberative. Like both of those have like good outcomes. And then BMI is included in this section. So also please note that the cutoffs are different for different ethnic groups as well. So like there's slightly lower, supposed to have slightly lower BMI to be within a healthy range for those groups. And also waist circumference can be used in combination with the BMI to work out healthy weight. And these are the cutoffs. Yeah. And just coming back to tremor again, so these are the frequencies of the tremor. So essential, no, why do I start with that? Intention tremor, so that's 2 to 3 hertz. Then you've got cerebellar tremor, that's also known as intention tremor as well sometimes. So it can be either that's a slow course tremor, and it can be seen also in lithium toxicity. And then Parkinsonian tremor, which is pill rolling, which is characteristic. And then essential tremor, which is most common type of tremor, and it's also sort of benign, and it's not associated with pathology. It usually starts in kind of middle age, affects the hands, and it's worse with like stress. And then physiologic tremor is basically the normal tremor that every person has, like whenever they're doing anything, there's always a slight tremor. And then psychogenic is kind of just comes and goes and gets better with distraction, but can be variable. Okay, great. So that was what I felt was like some of the key points from classification and assessment. I really hope that was useful. I really hope this whole series has been useful for you guys. I'd be really grateful if you could just take like 2 minutes, I mean less than 2 minutes, take like 1 minute just to fill out my evaluation that is going to be coming up when I end the webinar, and it should come up on your screen. And I probably will check in with you guys as well, if that's okay, just to see how your exam was and get any feedback from you. But thank you so much for giving me this opportunity to help be on your journey to passing the exam. I really hope that you've enjoyed it. I hope it's been useful. Your feedback's really valuable to me. I really wish you guys like all the best and so much success, and I hope you pass it first time or second time or third time, whatever time you're doing it. I just hope you pass it this time. But if you don't, like, again, don't stress. Like, these are really, really difficult exams, but fingers crossed, like the vibe will be good, and you know, I'm sure you guys have put in loads of work, so hopefully that will come through as well. So yeah, thank you so much, and it's been a pleasure. So look forward to hearing from you guys and your feedback, and I will keep in touch. So yeah, any questions, just drop me a line or put them in the chat, and I will get back to you by email or on the chat. So yeah, take care. Thank you so much, guys. Good luck, and wish you guys all the best.